Welcome you all. First of all, I would like to congratulate the Ferty9 team for organizing this full-day fertility education program. So let us start the session 1 on fertility capsules. It's my pleasure to introduce our first speaker, Dr. Kavya Reddy. She did her MBBS in Sri Devaraj URS Medical College, Kolar. She did her post-graduation DNB OBGY in Narayana Hrudayalaya, Bangalore. She worked as a consultant in Narayana Medical College for 2 years. She obtained her fellowship in reproductive medicine, Craft, Kodangallur, and worked as a fertility specialist in Craft Fertility Center for 1 year. Welcome, Dr. Kavya. She will be talking on female partner evaluation in the next 15 minutes.
Good morning, everyone. Welcome to the session. Let's start the session. The topic is female infertility.
So, infertility is a serious health worldwide issue which accounts for about 8 to 10% of the couple worldwide. According to WHO, in India, the prevalence of infertility is around 4 to 16%. According to NIH, also it is around 8%. Actually, the female factor contributes to infertility for about 40 to 55%. So, we have to know when to evaluate the female infertile woman. If the patient of ours is less than 35 years and married for more than 1 year and they are trying to conceive without any unprotected for more than 1 year, we have to evaluate this patient. If the patient is less than 35 years, 6 months of unprotected intercourse we have to evaluate. If the patient is more than 40 years, even married for only 6 months also, they have to be evaluated as soon as possible. Immediate evaluation is required. There are certain conditions like where early evaluation is required when the patient is coming with irregular menstrual cycles or cycle length, polymenorrhagia, intermenstrual bleeding, oligomenorrhea, we have to evaluate. We know that certain factors like uterine, tubal factors and peritoneal factors does contribute to the infertility. Any patients whom we know the patient is suffering from endometriosis, like we have done any laparoscopy where we find stage 1 and stage 2 endometriosis also, we have to treat the patient as soon as possible. And patients, couple we are having subfertile male infertility has to be treated. Sexual dysfunction has to be taken in the history. Like so many people don't even complain to us regarding ejaculatory dysfunction, erectile dysfunction, vaginismus, dyspareunia. Clear evaluation of these patients is very much important. And few genetic conditions and acquired conditions we have to know. And chemotherapy, radiotherapy patients, we have to go for early evaluation. Basic history is very, very important, and as well as physical examination. In the history comes to marital history, very important. According to ART guidelines now, if the patients are not more than 1 year of proper unprotected intercourse, we can't even treat the patient. So we have to first ask how many years of they are trying for pregnancy, and length of unprotected intercourse, coital frequency has to be asked. And nowadays people are using so many apps and kits like LH kits. We have to ask the questions so that we will understand whether the kit's been used properly or not. There are false positivity and false negativity rates with this LH kits. We have to train them how to use those kits so that the ovulation can be easily ovulation can be easily by them itself. Patient only can appreciate it. And few apps we won't be able to know the ovulation time properly. The menstrual history is very, very important. Even the patient is having irregular cycles also, we will have lack of ovulation. We have to take proper history. Dysmenorrhea history is important because sometimes secondary dysmenorrhea itself causes infertility. Coming to obstetric history, past obstetric history plays an important role. Medical and surgical history, proper weight gain and weight loss, and pelvic inflammatory disease, sexual transmitted diseases, hypertension and diabetes history has to be taken. And previous surgical history and chemotherapy has to be taken. Family history is very important because infertility in the family, or like mother is having early menopause less than 40 years, heritable cancer conditions like BRCA1, BRCA2, we have to evaluate these patients, and proper time management in infertility treatment help them save from so many other factors. Occupation hazard has to be ruled out, and treatment of previous like IUI, previous history of IVF has to be taken. Physical examination, as we learned in our PG days, it is very important. BMI plays a role. Thyroid enlargement can be missed in few cases if we don't examine. Breast examination is must because females don't tell us regarding breast secretions or any lump. They'll be shy to tell, so we have to go for breast examination even in the fertility management. Androgen excess symptoms can be easily visualized like hirsutism, acne and acanthosis nigrans. Pelvic examination is very important to rule out cervicitis, any Y discharge. Y discharge indicates like foul smelling discharge, anything indicates cervicitis, which again because of this, there are chances of infertility in these patients. So coming to the causes, tubal factors contributes to 40%, ovarian factors contributes to 40%, unexplained infertility and other factors to about 20%. In ovarian factors, mainly we have to evaluate whether the patient is ovulating or not. In history only we will come to know if the patient is having regular cycle, definitely they are having ovulation. Few patients will use LH kits and serum progesterone levels, whether we have to measure the serum progesterone levels. It is not the 21st day of the cycle we have to measure the serum progesterone. It 1 week before the onset of menses, serum progesterone we have to measure. Only the disadvantages of serum progesterone is on a single day there is 7 times fluctuation of serum progesterone seen in our body. So it's not the value of progesterone, like for example we get 10 in one patient or 1 in one patient. It is more than 3 indicates progesterone has been released, that means ovulation has happened in these patients. And transvaginal scan, obviously when we are following up the patient, ovulation in the transvaginal scan we will easily identify. The LH kits, they have to know how to use the LH kits. As you can see, exactly before the ovulation, 2 days before we have to start doing the LH kits. Unlike early morning sample, it's a midday sample and the evening sample will predict the LH kits. Usually LH search starts in the morning hours. So sometimes when we do LH in the morning hours, we won't be able to even find the 2 lines. So in the midday sample and the evening sample, the search can be easily predicted in the LH kits. It identifies the period of infertility. As you can see in this, there is a like dominant follicle, and in the next picture you can see the ovulation, where you can see decreasing in the size of the follicle. And when you see the scan, you can see identify the in POD you can identify the fluid, which together indicates the ovulation has been happened. And other things are ovarian reserve testing. Whether we have to do ovarian reserve testing for every patient. Nowadays people are getting married very late, and we have to identify which patient is having ovarian reserve decreased, because environmental factors and nutritional factors in nowadays, they are going to affect on our ovarian reserve. Not only the number, the quality of the oocytes have also been decreased. So ovarian reserve test mainly identifies the number but not the quality of the oocytes. So there are risk factors of the patient is more than 35 years, history of early menopause in the woman, genetic factors and fragile X permutations, and other conditions like previous history of ovarian surgery. Salpingectomy does contributes to decrease in the ovarian reserve, because if you are there is decreased supply to the ovarian reserve, then the quality of the oocyte and the number might come down. Chemotherapy, radiotherapy patients and autoimmune inflammatory diseases, laparoscopic ovarian drilling in unindicated patients, some stress also decrease, and smoking history, endometriomas. There is a study which is done, this study is called an error study. In this study what they have done is, they have compared an endometrioma patient and in non-endometrioma patients. Only in a patient who is having endometrioma, you can see there is 26% decrease in the serum AMH levels, which is very much faster when compared to a normal woman. So in a patient who is having endometrioma, ovulation induction and IUI has to be done as soon as possible, depending on the age of the patients. So the main purpose of ovarian reserve testing is, it predicts the reserve, and we can also identify the decreased ovarian reserve patients as soon as possible, and we can coordinate the treatment. And the main part is the counseling becomes very easy after doing ovarian reserve testing and planning the treatment options. So the different ovarian reserve testings, one is a biological test, biological methods, biochemical methods, biophysiological methods. Histological methods are not done. In the biological methods, age, female age is the single most predictor for fecundity. As we all know, the maximum number of oocytes are present in our body around 6 to 7 millions when we are fetus, at fetal life. They become to 3 lakh by the time we achieve puberty, and more than 35 years of age, the oocyte number will be gradually decreasing. As you can see this graph, where you can see the green line, where maximum number is present at 18 to 22 weeks. As the age increases, there is further decrease in the fertility rate. And the dotted line which is present below, this particular patient is have reserve at the birth only very less. So these patients will have more decrease in the reserve when compared to a normal patients. This is a slide where you can see the total number of follicles, where total number of follicles are more. So because of which AMH will be normal. When compared to the other patient who is older, the total follicles are less, so AMH is decreased in this patient. So there are other factors like inflammatory aging, which is being identified nowadays, because our body will have chronic inflammatory changes which is going happen continuously in the body. Because of these changes, there is a difference between anti-inflammatory factors and pro-inflammatory. When there is imbalance, these particular patients will go for premature ovarian insufficiency. Any factors, any treatment is there to treat this patient? No, it is we are way ahead to maintain the treatment, to go ahead with this treatment. There are no particular interventions in this patients. So this slide indicates when there is decreased follicular pool, like decreased in the ovarian reserve. So first of all, what thing we observe is there is decrease in the AMH in this patient, which further causes decrease in the inhibin levels. So AMH and inhibin both cause negative inhibition on the FSH. There is central inhibition. When there is decrease in the central inhibition, there is increase in the FSH, which we can identify on day 2 of your cycle. So because of which when there is increase in the FSH on day 2 of the cycle, what will happen to these patients? There is early development of the follicles. The dominant follicle, which is supposed to be developed around 12 to 13 days or 14 days, the dominant follicle will be developing around 9 to 10 days only. These people will have decrease in the cycle length. So these patients will have decreased cycle length when we are doing basal estradiol level on day 2 of cycle, where they will have increase in the estrogen in them. So anti-Mullerian hormone, it is easily available now. 5 years back, there are different protocols by which AMH is being done. So there is lot of interchangeability in each protocol being used. Because of the second generation techniques what we are using in AMH measurements, AMH is very easy to measure now. The anti-Mullerian hormone is mainly produced from the granulosa cells which is present around the oocytes. So this measurement of this hormone is very easy, and it is the first hormone to come down, and it is very easy to predict the decrease ovarian reserve. So this hormone normal ranges are 2 to 6.8. It is gonadotrophin independent. Intercycle variability is very less in this particular hormone, and the constancy is maintained between the cycle. It is more sensitive than FSH, and it tends to decline even before the FSH. So like few patients, if we can see AMH, like a 26 or 27 lady will come, and we see AMH of like 2 one time, and only 1 milligram we can see. Like we have to ask history of hormonal contraceptive pills. Continuous usage of hormone contraceptive pills for more than 1 year. It's more than 1 year, not for 1 or 2 months. There is decrease in the AMH about 15 to 55%, which is observed. So this when the AMH is less, we have to take this following history also. So what is the action of anti-Mullerian hormone? Mainly it acts as a gatekeeper, and it protects the follicular recruitment. It suppresses the cyclic recruitment of the primordial follicle, and it maintains the antral follicular pool. So it has inhibitory effect on follicular activation and growth, and it inhibits the FSH stimulated growth, and inhibitory effect on the aromatase. So as we know, low AMH, we are worried. High AMH also we are worried, because high AMH, when it is there, it will convert the estrogenic environment into androgenic environment, which is mainly seen in patients like PCOD. This is also little worrisome. So other factors like a follicle stimulating hormone and day 2 hormone, it should be done together for a better success rate. If follicle stimulating hormone, if it is more than 10 milli international units per day on the day 2 of menstrual cycle, there is poor response to the ovarian stimulation, where we can counsel the patient together with the treatment. Inhibin B, and there are few dynamic tests, they are not recommended nowadays. So this is a table where you can see a normal reserve patient and low ovarian reserve patients. So when the AFC is more than 10, their granulosa cell number will be more than 10. So inhibin will be normal for this patient, and AMH normal. The cycle length will be maintained. On FSH, if you see on day 2, their FSH is less than 8. When it comes to a low ovarian reserve patients, where the AFC is less than 5 to 7, the total granulosa cell number around the oocytes are also less, because of which AMH is decreased. There is decrease in the length of the periods. On FSH is more than 8. Biophysical markers are antral follicular count. It is very easy to measure. Antral follicular count has to be done on day 2 or day 3 of the cycle, which is the basal scan, low intercycle variability, and it also predicts the response to the gonadotrophin on that cycle day. And the normal number of AFC are 10 to 18. Anything less than 7, we should be worried, and more than 20 indicates a hyper response, which is mainly seen in PCOD patients. So when you want to go for one test, whether it is AFC, AMH or FSH, all three are good enough. But if you know, like better scan, if you can perform a scan on day 2 properly, AFC is a reasonable alternative to AMH levels, and it will be easily predicting that particular cycle prognosis in the patients. So ovarian volume, lack of sensitivity exists in ovarian volume, because if there is any ovarian cyst, so we can see different volume. The normal ovarian volume is between 3 to 10. More than 10 is observed in PCOD patients, ovarian cyst patient. If the volume is less than 3, it is a low ovarian reserve patient, or it is seen in the perimenopausal and menopausal ladies. So tubal factors are also be equally monitored, because if there is only patency tube, we can go for any normal treatment like IUI and ovulation induction. Most commonly done procedure is the HSG procedure, where we use a ionizing dye and it is done under X-ray. So it can predict the bilateral tubal patency also, and it also have ability to predict the peritubal adhesions like phimosis, and loculated peritoneal deposits also we can find. This is a picture of HSG, and SIS is an alternative to HSG. All the advantages of SIS is intrauterine lesions like intrauterine polyps can be easily identified. The first picture is a normal SIS. The second, you can identify the polyp in the intrauterine cavity. This is a picture of submucosal fibroid. So next, how do you differentiate between a polyp and submucosal fibroid in SIS? If it is a polyp, it is mostly echogenic to the endometrium. Definitely the polyp is arising from the endometrium. When it comes to a submucosal polyp, it is hypoechoic relative to the endometrium, and it is overlying echogenic layer is present, that is called endometrium. There is only one feeding vessel which is seen with a polyp. When it comes to a submucosal fibroid, definitely you can see a circular type of pattern, and in polyp, there is preserved endometrial and myometrial interface. It is distorted in case of submucosal fibroid. This is a procedure called HICOC. It is an alternative to HSG and SIS. Only advantages of this procedure is no need of exposure to ionizing radiations, no need of exposure to X-ray. So in this procedure, what they are going to do is, there is a foam dye solution. So the foam dye is available in a kit. This can be done as an OPD procedure also. The dye along with the intrauterine catheter, which is provided by the kit only, we can directly introduce this foam gel directly into the uterine cavity. As you can see the 3D image which is present in the next picture, you can take a whole picture of uterus and the fallopian tube. It is the same like SIS, but SIS, what is the disadvantage is, you can't differentiate between a unilateral patency and bilateral patency. Like in HICOC, you can identify the bilateral patency along with intrauterine abnormalities also. So uterine factors are also important. In 16.2% of the patients of infertility are suffering from uterine factors. The most common are polyps, submucosal fibroids, and Asherman syndromes. And before going for the treatment, we have to rule out Mullerian abnormalities, fibroid, endometriosis, adenomyosis, endometrial polyps. So whether you have to monitor the cervix also, hostile cervical mucus, stenosis we have to be making sure before going to the treatment, cervical polyps, and chronic cervicitis. Chronic cervicitis has to be treated. Even though there is no role of anti-sperm antibody, when there is infection, definitely the motility of the sperm will be affected in these particular patients. So there are few tests which need not be done for all the patients who are suffering for infertility. That is, laparoscopy for unexplained infertility is not required. DNA fragmentation test is most commonly misused test nowadays, not for all the patients. Postcoital testing is not required. Thrombophilia profile and karyotyping is not required until the patient is having previous history of recurrent pregnancy loss. Endometrial biopsy and prolactin. Prolactin need not be done for all the patients, only if the patient is having irregular cycles and galactorrhea and complaining of severe headache. So as a rule out as a fertility profile, we have to do the prolactin levels. So the summary is, female age is most important factor for the fecundity and the fertility. So we have to categorize the patients into normal fertility women and abnormal fertility irrespective of the age, I say, because nowadays irrespective of the age, the female fecundity is decreasing, and AMH, AFC are most sensitive and specific tests which can be used for the ovarian reserve testing. And markers of ovarian reserve testing are good predictors of oocyte yield, and they are poor independent factors for reproductive potential. Just because AMH is less, we can't tell the patient you can't go for the treatment. We have to give the treatment for this particular couple. HSG and SIS can be done to evaluate tubal patency with equal effectiveness. So every couple deserves bundle of joy. Thank you.
And it's a very nice talk. She stressed upon the importance of history, physical examination, and brought out the differences between the points that need to be brought out in a very nice, clear way. I know that she has a very bright future ahead of her. Congratulate you once again.